Uh, Welcome, everybody. So this is another update from the ReIMAGINE team, and we're really grateful to all of you, who are attending today. A lot of you were very positive about the last meeting, but we had a few problems, as you remember, drifting in and out of different rooms. We also had quite a lot of suggestions for future topics, and we're going to cover quite a lot of those today. So today is kind of brief, punchy updates on really important areas in prostate cancer. And we're going to cover things like screening, artificial intelligence, what COVID-19 has done for research. We're also going to debate one of the really hot topics, on how we do MRI. Do we do the full multi-parametric, or can we do a short sequence MRI, which will be really interesting to see where that lands. And so that'll take us through to about 6:30. And after each presentation, there'll be a few minutes for discussion. So if you have any questions, put them in the chat. And Steve is going to be scrutinizing those questions and come out with the best questions, or the ones that he thinks most highlight that one of the kind of key issues, or to straighten out some of the aspects of the presentation that perhaps weren't as clear as we thought it was. So we're looking forward to a wonderful program. Thank you once again for attending. And I think with that, we'll start ahead of time, and I'll introduce Caroline Moore, who's going to update us on the challenges of screening for prostate cancer. So Caroline, would you share your screen?
Caroline, you're on mute.
Sorry, thought I've got the hang of this by this point in the pandemic, wouldn't you? Long day. So thanks for the chance to speak to you, and lovely to see lots of familiar names, but also some new names in the chat of people joining today. So prostate cancer, 52,000 men diagnosed in 2018, 2019, which is the latest year that we've got the data from. And 13% of those men presented with metastatic disease. That is much higher than the numbers that we see in other countries. So in the US, it was previously around 4% and has slowly risen to about 8% as they've reduced their PSA testing. And in Australia and New Zealand, it's been around 7% since they started collecting data. Screening would help, or aims to detect cancer before it gets to that metastatic stage. The definition of screening is it's offered to people at the population level, and it needs to be both effective and cost effective. And essentially, there's a balance between early diagnosis and overdiagnosis. And historically, we haven't always got that right. And that's essentially why the UK doesn't have a screening programme. So if we put together all the results from all of the screening studies so far, we'd see that essentially PSA screening wouldn't change the number of men dying of prostate cancer, but would change the number of men treated for prostate cancer. And the estimate is that about 20 of 100 men would be overdiagnosed in that situation. And that summary of the evidence is essentially why the UK doesn't have a current screening programme. However, there is one study that has shown a reduction in prostate cancer mortality from a traditional screening programme. So the European randomised study, invitations every 2 to 4 years, and any man with an abnormal feeling prostate or a PSA over 3 got a test. They showed a 20% reduction in prostate cancer deaths at 16 years, so quite a long time. But their overdiagnosis rate, so the number of men diagnosed with prostate cancer, about 40% of men diagnosed with prostate cancer had indolent cancers that weren't going to cause harm. The European Association, which covers obviously a lot of different countries, suggests doing a PSA at age 45 and then rechecking it with the time interval depending on that PSA result. And consider the following: risk calculators, MRI, and new tests before you decide who to biopsy. The American recommendations from the American Urology Association say only offer a PSA to a man between 40 and 54 if he has a positive family history or is African American. And then once men get to 55, consider screening every couple of years. In the UK, as many of you will know, the rules are that you can ask to talk to your GP about prostate cancer. And once you've discussed the pros and cons that many of us spend, hours and hours discussing, and a GP has 8 minutes or less to discuss, then you can have a PSA test if you want one. But we also know that there's a real variation in PSA thresholds across the country, and that some areas of the country change their PSA thresholds because of COVID. A UK screening study using a single PSA test showed no reduction in prostate cancer death at 10 years. So we know that that doesn't work. So far, we've got a lot of things that don't work or don't work very well. And how can we change that? How can we screen smarter? Well, this slide shows a meta-analysis of a number of different studies looking at men not detected through screening, but referred by their GP or family doctor into the hospital, and they've had an MRI scan compared to a standard biopsy. And essentially what we know is that MRI in the hospital setting, when men have been referred in because their PSA was raised, is much better than standard biopsy. So it allows at least 1 in 3 men to avoid a biopsy safely. It detects more of the disease that we want to detect, the aggressive disease, and it roughly halves the detection of indolent disease. So the next question is, can we use it as a screening tool? And of course, ReIMAGINE screening was set up exactly for that. So what we set out to find out is how many men will respond to an invitation for a prostate health check. And of those men who respond, are they the men at highest risk or not? And then the second question, how many of those men would have a lesion on MRI, and how many would have a high PSA for their prostate size? So the study diagram, men were selected at the level of the GP practice. So you can only take part if your GP practice was taking part, and you would receive an invitation based on your age and not meeting any exclusion criteria. You then get a letter through the post, and if you like the sound of it, you phone and leave a message and then have a conversation with one of the study team. And if you're suitable, come in and have the screening test, which was an MRI scan and a PSA test. If you screen negative, you and your GP are told about that and you exit. If you're positive, then you're referred into the standard NHS services. So this is a man who had a negative scan, really nice bright white peripheral zone, no sign of cancer there, and he got the reassuring letter. And here we have a positive area, and so this man was referred into his NHS trust for further investigation. So COVID arrived, as we all know, far too well. As you would expect, all non-COVID studies were paused at UCH and at all other sites across the country. Although our clinical referral service, if the GP was worried or the MRI, the PSA was high, it could still be accessed. We were allowed to reopen it in July. And of course, we were worried that nobody would want to come to the hospital. We were hearing stories of people not wanting to come to hospital if they had a heart attack. So why would they want to come for a screening study? And so we spoke to our patient and public representative group to ask what we could do to help to reassure men. And in fact, I'm not sure if Mark is here today, but I'm just going to show you the video, which I hope will work.
Today I'm here at UCLH for an MRI scan for the ReIMAGINE prostate cancer screening study. The first stop into the hospital is the sanitation section. This is where you're going to be required to make sure you sanitize your hands, and if you haven't got a mask, you can pick one up. Before my visit, I was asked all the appropriate questions regarding any COVID-19 symptoms, etc. in the event that I might need to reschedule my MRI scan. I'm symptom-free. The ReIMAGINE prostate cancer screening team have coordinated appointments in such a way that there is no overlap, and today the scanner will be used by ReIMAGINE participants only. The MRI scanner used for the study is in a controlled area of the hospital with an adjoining spacious private room. So there is minimal human contact, no physical examination, and all the equipment has been disinfected before use. I'm all done, less than 60 minutes in total. The ReIMAGINE team couldn't have done more to reassure and safeguard my visit today for my MRI scan. And there's my cab, courtesy of ReIMAGINE.
So we see then what happened to our recruitment rate. So this was our initial recruitment rate. And then, of course, we had COVID, no recruitment as you would expect, and then an even steeper trajectory. So that video and willingness of people to come forward combined to reach our target ahead of time. The impact of our patient and public engagement group has been recognised by others as well. So there'll be a poster at the BAUS conference, the British Urology Conference next week. And Saren has had an article published in the Cancer Researcher about diversity and inclusion in research based on our work in ReIMAGINE. So lots to celebrate there. Now, of course, what you really might be waiting for is the results. And I'm afraid I'm not going to be revealing any of them, essentially because we're still working on analysing those results, and we look forward to bringing them to you later in the year, but not just yet. So in summary, traditional screening programs show an effect after many years, but at the expense of significant overdiagnosis. And we know that overdiagnosis can often lead to overtreatment. Modern screening will differ because we will look for clinically significant disease. We'll use MRI and targeted biopsies where we need to, and we'll be looking to focus things on men at highest risk, and that may well include ethnicity and family history. I'm happy to have any questions.
Caroline, thank you very much indeed for that. That's great. And we're ahead of schedule. Let's keep it that way. So I'll hand over to Steve, who's been scrutinizing the questions, which have come largely from the panel, but that's okay, because the panel need educating as well as the audience. But there have been some questions from the audience. So Steve, over to you.
Yeah, thanks, Mark. Yeah, and some of them are just coming in now as well. So people are obviously very absorbed in your presentation and the video, Caroline. So some nice feedback on the video as well. In fact, one of the questions there was, how was the video disseminated and who saw it? Was that just a link to potential participants?
Yeah, so there was information about the website in the letter, and then the video was available on the website, because our initial communication was simply a letter, a physical letter. There wasn't a way to sort of text it to people or do anything more direct than that. So you had to show some interest before you got to see the video, essentially, although it's also available freely on the ReIMAGINE website. But yeah.
Okay. So one of the questions that came from the panel, so let me deal with one of those. Is overdiagnosis a bad thing if you don't overtreat?
Okay, excellent question. So yes, I think it's a really bad thing. So in the UK, we're quite good at not overtreating, but even being on surveillance, if you don't need to, can be worrisome. So across the UK, about 25% of men on surveillance choose to have radical treatment rather than keep being monitored and keep being worried. So surveillance is an answer to overdiagnosis, but actually not diagnosing those men for their own sake, because if they're not truly at risk, then being told you are can bring all sorts of issues. And also for the sake of the health service and the health economic aspects, because overdiagnosis is really quite costly in lots of ways. And if we can avoid that, we'd save more money for those MRI scans that we want to use.
Okay, thank you, Caroline. Recently, ovarian cancer screening for women was shown not to reduce premature death. Do we know why that might be the case?
So I don't know lots about ovarian cancer. I would imagine they're not catching the right people at the right time. But more than that, I wouldn't have many answers in the ovarian cancer setting.
Okay. And a couple thinking about, so we don't want to talk about the early results and so on at the moment, but should MRI screening prove to be feasible and effective, would it be, how would that roll out, and would it be cost efficient to use MRI scanning for screening men?
So the exact details of that we haven't worked out as yet, but what we know is that having the highest rate of diagnosis of metastatic disease in the world at presentation is really expensive. And it's really expensive in pure monetary terms. It's much cheaper to treat somebody's localized cancer than it is to treat and support them in metastatic disease. And of course, it's also much better in human terms as well. We would all much prefer, if it were possible, to be diagnosed with an early tumor that can have a small treatment than to be diagnosed at the other end of the spectrum of disease. And I think because the treatment of metastatic disease is so expensive, I expect that the health economic calculations will work out, as well as providing big benefits for people.
Okay. There's a question here. So, in the current world, the early tests that we have as men are a PSA test, so a blood test, and a digital rectal exam. What part does the digital rectal exam play in this world of MRI and biopsy for screening? How does it add value?
So I think it doesn't have a role to play, actually. I think this is the screening test where you keep your trousers on. I think that will encourage men to come forward to be screened. And we haven't shown any additive benefit of digital rectal examination when we have MRI scans. We know that there can be some benefit when there's no MRI scan, but we haven't shown any additive benefit of a digital rectal examination to an MRI scan. So I think it won't play a part.
Okay, thank you. And we're still okay for time, so let's.
Well, actually, we could move on and then stay ahead of time, so we'll have more.
All right, Mark.
Time at the end,
okay.
if you want.
Yeah.
So that's good. I've not heard that one before, actually. That this is a screening test where you keep your trousers on, and I think that's a really important attribute of the test. Actually, that a lot of men were very worried. There's a question at the bottom about using digital rectal exam. And a lot of men don't come forward because they don't want that to happen to them, and which is very understandable. So, so Caroline, thank you. That was really helpful, very insightful. Screening sounds simple, but it's not. It's the opposite. Muir Gray used to describe it, who's our screening guru in the UK, as a veil of tears. And the kind of more you understand it, the more complicated it gets. And obviously one doesn't want to harm anybody, or one wants to harm as few people as possible, whilst at the same time conferring as much benefit. And getting that balance in medicine is always very, very challenging. So we're going to now move to artificial intelligence. No conference is complete without a session on artificial intelligence. And Charlotte Punwani is going to tell us whether MRI machines will feel emotion whilst they're scanning our patients for prostate cancer. Charlotte.
Excellent, thank you, Mark. Yes, so a little bit about artificial intelligence, specifically prostate cancer. So Caroline's already shown you that the pathway for diagnosing prostate cancer has changed. The important thing here is that we've introduced MRI to localize the lesion, and then the biopsy targets that localized lesion. So I'll talk you through why we need something else by talking you through the steps from here to here. Okay, so this is the sort of MRI scan that we may have. We've got multiple images, and this would come to me as a radiologist to look at. And I would have to identify a lesion on this scan which is suspicious. And you can see there's something here on all of these images which look at various aspects of tissue anatomy, cellularity, and vascularity. And I would be pointing this lesion out to Mark and Caroline to biopsy. This is the sort of report they might get from me, which will tell them where the lesions are within the prostate. But more importantly, let me draw your attention to this table here. This is my human intelligence, hopefully, telling them what the probability might be in the numbers from 1 to 5 of whether a lesion is likely to be tumor or not. 5, highly likely. 1, unlikely to be anything significant. 3, I don't know. Okay, so this is the sort of thing that multiparametric MRI gives for urologists at the moment, and biopsies then get done. And Caroline has already pointed out that what we're trying to detect is this stuff, the 3+4 or higher tumor, the red disease, not the green disease, which is not going to be of benefit detecting. So all the scoring that I'm doing is trying to detect this significant disease. But no matter how hard I try, and no matter how good the MRI scan is, about 10% of disease I won't be able to pick up, a significant disease on an MR scan. Moreover, if you look at the patients that I do find a lesion on, about 50% of the lesions when they're biopsied will not turn out to be tumor. Okay, so the sensitivity is very high, but the specificity is not very high. It's about 50%. So 1 in 2 men will undergo a biopsy and not have tumor on their MR. That's not just me, that's all radiologists combined, and various studies have shown exactly this effect. So we can do better. And the question we're asking now is, can we get artificial intelligence to do better? So you might think about artificial intelligence, and you might think about Star Wars, and you might think of this guy here sitting there reporting scans, but that's not what we're doing at all. This is what we're doing. We've got narrow AI. Narrow AI means we're asking a single question. We're asking, is this a dog? Is this a cat? To you or me, it might be fairly straightforward to know this is not a cat, but he's got a flat face, the cat's got a flat face, and it might be difficult for AI. So AI is complicated in terms of how to get it to work. But it's this sort of thing we're asking in imaging. There are lots of terms that come up in artificial intelligence. Artificial intelligence basically just means machines that act like humans. What we're doing is machine learning, which is a part of artificial intelligence, and it's about how we can train machines using data to make decisions. And then within that, which has really revolutionized what we can do and what we're driving around now with Teslas and so on, is this deep learning approach. And that's because we've got very fast computers. And this deep learning approach is a method of giving vast amounts of data and asking multiple questions sequentially off the data in order to make a decision. So what do I mean by that? So here's a square, we think. If I ask a computer, what is this a square? It has to ask several questions. Does it have 4 sides? Are the sides connected and closed? And if yes, are the sides perpendicular? If yes, are the sides equal? If they're all yes, then it will define this as a square. So these are layers of the network that a deep learning process puts in place. And then with deep learning, what you actually get it to do is you give it lots of data of cats, lots of data of dogs, and it automatically finds these layers. And if you have lots and lots of data, it has lots and lots and lots of layers. So eventually you get to a situation that the performance of that deep learning network is very, very high, which is where you can turn your autopilot on in your car. And we can do that with imaging. And this is exactly the sort of thing we're trying to do to get a deep learning network through this approach to identify cancer or not. So what are the potential benefits? Well, it may find features that I do not pick up. I mean, I'd always be looking for whiskers on a cat, but it may find something else completely that identifies a cat. It's not going to get tired. I'll get tired after reporting, I don't know how many other scans, but it will carry on forever. And it will probably end up being faster with the faster the computers get. So how do we get this to work? Well, we have to train it. So this is my clinical fellow who's done a lot of the slides for me here, who has been training in prostate. He's got his prior knowledge, which is looking at lots of prostate scans and reading books. He then gets the data in terms of trying to work out whether this patient has a cancer or not. He will make a decision, and that decision would come to me, and I would either tell him, oh, I don't think so, or I do think so, and then get feedback, and he'd learn from that. This is the same way that the deep learning artificial intelligence itself learns, by having the right feedback on outputs and then improves. And in the case of artificial intelligence, it may be the biopsy results that provide that feedback. In the end, what we're trying to do, what looks like a complex diagram here, is to get from all the input here into an output through whichever process of classifying and trying to work out here whether somebody has tumor or not, or give a probability of tumor, or even replace a radiologist and actually draw the lesion for you on the MR image. And these are all approaches that are being investigated. So Tom and Pritesh have done a lot of work on this, looking in the literature, and actually found that it's not done very well. Out of all the data that they look at, only 27 clinical studies could be identified, and there were lots of problems with the studies, which basically meant that they're unlikely to work in their present form. But having said that, there are examples of how it might work. Here was one study where they tried to classify a lesion, and it was scored positive, and then they used the model to determine whether it should have biopsy or not, and they found that by using this model, they could potentially avoid 34% of patients from having a biopsy unnecessarily without missing any tumors. So there is potential, but there needs to be development. We need more data, we need better quality data, we need a diversity of data, and we need to be able to share data. And that's the sort of work that we're trying to do now. And ReIMAGINE is spearheading part of this, because we have a large number of patients involved. We have multiple scanners involved from multiple sites. We have very well validated data, so high quality data, and we're working with a number of AI partners across the world to develop their algorithms so that they can get them into a state that we feel can be applied clinically. So what is our challenge in ReIMAGINE? One of the things we'll be looking at is, can we actually get biopsy safely avoided when I score something which I'm not sure about? Can this make a decision for me? So we'll find that out. We might even find out that we can get the Gleason grade directly from the image. And wouldn't it be fantastic if you could do that and you could actually make a treatment decision directly from an image without a biopsy? I mean, it's a bit of a way off, but it may well happen. And by adding ReIMAGINE data to other data sets, we have men who have had normal MRIs. We can ask the question, can we actually get a radiologist not to report every single scan, get all the normal scans perhaps reported automatically, and the radiologist concentrates on the more difficult ones. So these are all things which will come, hopefully, out of the ReIMAGINE project. So I'd like to thank Tom and Pritesh for a lot of the work that they've done here, and ReIMAGINE and the patients involved for the work, for donating their time and effort into this. So thank you very much.
Charlotte, that was a fantastic introduction into a very complex area. So thank you for that. But you didn't tell us whether MRIs would feel emotion. Very good
As
article.
much as a radiologist, Mark. So we could take that.
That's a no then. That's a no. That's a no. Okay. Steve, over to you. Any questions that caught your fancy?
I didn't see any coming. We still had some follow-ups on DRE, but I did come up with a question, which, Shonit, you were talking about providing feedback to someone learning training as a radiologist. You providing feedback to Tom, I think, was the example. And we all know that you can learn things that are wrong, and sometimes you need to be corrected. Who is it, and how do we tell a computer that's learning these things really quickly? You talked about the speed of processing. How do we tell the computer when it's wrong?
Yes, it's a very good question. I think the first question is about how do you train someone or a computer correctly, and that requires the quality of the data to be good. So if I have a particular performance level, Tom probably won't be any better than me. But if I can find a better way of getting my data quality up, so if I just look at the biopsy patient, he would then get much more specific feedback, and he might even improve further and perform better. So the quality of the data is really important. In terms of how do you tell whether an AI system is effective or not, is a very good question. So it's really asking the question, at which point in time would you be happy to allow your car to drive itself? The proof is in the pudding. So you've got to get to a stage where you can be confident to let that happen, and you might actually perform better than the human.
Yeah.
And I think there's a lot of PPI work that needs to go into understanding that in medicine as well.
And Shonit, I think one of the things in that car driving, one of the things they talk about there is about consistency. So whilst it may not be right, and sometimes there's no good outcome, but it's about consistency of outcome. Is that the same true for diagnosis as well?
Yeah, absolutely. So there's a lot of debate in terms of should a AI system be explainable or not. So some of these deep learning models, you don't know what they're looking at to give you the answer, in which case, how do you explain why they've got the answer and whether it's right or wrong? So people are trying to simplify the models so that they become explainable and are therefore consistent and understandable.
Okay. And is this technology being used, a question from Andrew here, is this sort of technology already being used successfully for other cancers?
There are various packages available which allow you to assist radiologists in identifying tumours. But I do not know of a single package that automatically does everything and avoids radiologist input at this moment. So I don't think we're at that stage yet.
I was thinking, a few years back, I mean, we saw a number of recalls, I think, around interpreting mammograms, where unfortunately women had been sometimes diagnosed when they shouldn't have been and had undergone procedures, and the opposite. So I guess that's back to that consistency question again then.
Yep. And the question we need to ask ourselves really is, how good do we want an AI system to be? If it's better than your best radiologist, is that good enough? Or do you need it to be perfect? And that is a society question that we really need to answer.
Cool, thank you. Okay, I think we're there with the questions, I think. Fantastic.
We'll have an opportunity again to come back to kind of ask any other questions or see if any themes develop in the chat. So we're at 100, or we're down to 99. Somebody's gone off for a cup of tea. We were at 100 participants, which I think is fantastic. And I hope and trust that you're enjoying it. So we've done screening, we've done AI, and of course, AI and screening, if we can automate the process of screening and, maybe do an MRI in a place that doesn't need a doctor or a nurse to be present, so you really address the costs and you analyze it in the way that Shonit has suggested, so in a kind of semi-automatic manner, you can see the costs of screening plummeting. And that, of course, makes it a lot more amenable to funding. So we're now going to learn a little bit about what COVID-19 did to research, but I think there's also a huge opportunity to learn from what the positive aspects of COVID-19 on the way that we approach research questions. In fact, there was something on Radio 4 last week on this, and what we can learn from the rapid way that we've done COVID-19 research. So and I think there is a lot to learn. I think we're all still learning from it. But two people that have been watching this space very closely to see what we can extract to improve prostate cancer research is Mika van Hemmelrich and Dr. Louise Fox. And we're going to hear from both of them, possibly, or certainly Mika, who's going to really take us through this area now. So we look forward to seeing what we can learn from the last 18 months, Mika. Thank you very much.
Thank you, Mark. So yes, I'm actually going to present on behalf of Louis because he's actually in between contracts, but I'll hire him again by the end of the month. But Louis has done a study which we call the CCRES study, which is COVID-19 and Cancer Research Engagement Study. So this is not purely ReIMAGINE, but it does inform how ReIMAGINE and any other kind of study really should think about recruitment, given that COVID-19 has happened. And so we know that COVID has had a major effect on cancer research when it comes to recruiting patients into studies, but also obviously we know funding might have been affected. And so what we wanted to do is we wanted to kind of understand what is it that we as researchers can do to help patients feel confident to keep engaging in research, because obviously cancer patients are often told that they have to shield, so they don't want to come into the hospital. But then some studies that we want to recruit patients to, you might actually have to come into the hospital. So we wanted to get a better understanding of how COVID is affecting patients' willingness to be involved in research. And so the way we did that is 2 steps. So we ran a survey and we also interviewed patients. And so we distributed our survey between the 5th and the 19th of June last year, and we contacted 85 cancer patient organizations.
I didn't realize, I thought you didn't know.
And so about 26 of these worked with us. So we were looking at adult patients, so people with a cancer diagnosis, and we had information about their tumor characteristics, some demographic characteristics, and then we specifically asked them about concerns regarding COVID-19 and anxiety. And more specifically, we actually looked at, are there differences between men and women when it comes to potential anxiety related to COVID-19? And so we had just under 100 participants. And if you look at the table, so you can see that there was slightly more men, so 60% were male and 40% were women. And if you look at the age distribution, it's fairly representative of what we know the age distribution is of our cancer patients. So we had more patients of the age over 50. Then we had quite a spread of different cancer types, but you can see the prostate cancer patient community has been very generous and very much engaged in our survey. And then we had different kind of treatments. And so what we found is that women actually reported higher anxiety scores and concerns about participating in cancer research during COVID compared to men. And what we also saw in women is that the more anxiety there was, the less likely they wanted to participate in research. And so that is also shown here on this figure. So what we show here is the concerns, and on the what we call the axis here, so at the bottom is the concerns, and then on the y-axis here we show levels of anxiety. And so with men there is not really a pattern, but with women you can see that if anxiety goes up, the concerns go up as well. So there really is a trend, an upwards trend here. So the more anxiety there is, the more concerns there are about participating in research. And so the main finding really here is that it's generally affecting women. So that was the first study we did, which is published now as well. And so Louis kind of drove that study, also in collaboration with eCancer. So Catherine here is working for eCancer, and as many of you know, eCancer is our partner when it comes to advertising, communicating our study findings in ReIMAGINE. But now it's all good and well to do this survey. It just gives us something, right? But what should we do? How can we address that? How can we encourage patients to participate in research? So what we then did is a qualitative study. So yes, we have collected the numbers, but then what we wanted to do is really talk to patients. So we got ethical approval in place to recruit cancer patients. We advertised on Twitter. We worked with different cancer organizations again to kind of help us retweet. And then Louis and the team interviewed 13 patients to get a better understanding really of what is it that makes cancer patients decide to participate in research. And ultimately what we concluded from all the findings is that it's very similar to the cost-benefit analysis, if you like. So it's about what is the risk of getting an infection by participating in research versus the benefits of participating in the study. What is the benefits for myself as a participant, and how am I contributing to society? So in a little bit more detail here. So what were the how did they look at risk of getting infected? And I think this is quite interesting for us as researchers. So it's all about the confidence patients have in their healthcare professionals, in the study materials and the protocol, where the study is happening. Can they get there in a car, or do they have to get on public transport? And then when it comes to the benefits, it's about the benefit for themselves or the benefit for society. And so also thinking about, is the study vital? Will it help to really make a change in the treatment decisions for a cancer patient in the future? And so we are now in the process of writing up all these findings, but what we can conclude here, that it's very important for us as researchers going forward that we are aware of these anxiety issues, the concerns that cancer patients have. And so it really means that we have to work with the patients and the public when we're designing studies to make sure that we balance the risk and benefits correctly. And I think we can say, based on what Caroline has shown you, so, ReIMAGINE is an excellent example here, because we've had this fantastic recruitment into the screening study. But part of the reason is there that we actually, worked with the patients, identified how to give them the information, reduce the risk of infection by offering them transport to come into the hospital. So it's quite nice actually to see that what we found in our study is very much in line with what our patient support group in ReIMAGINE also suggested. And so with that, I would like to just say thank you to our team, because they've done a fantastic job throughout COVID, setting up these 2 studies and engaging with patients. Thank you.
Great. Well, that was fantastic, Mika. And it's great to know that this research is ongoing and that we're all learning from this experience. So, Steve, anything coming up on this subject?
So I have a question for Mika. So Mika, Caroline shared the graph that showed the impact of COVID. We saw the flattening through the first lockdown, and then we saw the very steep recruitment, which I think I think it's fair to say, given the reassurance that you were able to give to patients and the video and the protocols in place. We saw that recruitment actually faster than before the initial lockdown. Do we have comparisons to other studies? And have you looked at the impact on other studies or trials and patient recruitment?
So I think that's a very good question, but I think it's also one that is very difficult to answer, because we were very lucky also with ReIMAGINE that we got the green light from the research and development department in the various hospitals to go ahead and start recruitment. So I have lots of other studies open at Guy's Hospital, and I'm still not recruiting because we still haven't had the green light, because there is such a backlog and they're focusing on all the COVID related studies. So to answer your question, we would have to really look at another study that was given permission to open and yeah, so I would say it's actually quite difficult to answer at the moment, because we have these issues with recruiting still.
Okay, thank you. I can't see anything else there. If anybody has a question, please pop it in the chat.
I'll ask something while we're waiting. So Mika, I think patients and the public often get frustrated how long it takes to get study approvals. And suddenly with COVID, we saw stuff going through really, really quickly. And we saw people publishing the results without peer review, which is, what do you think? Are we going to learn from that, or are we just going to go back to the old ways?
Well, I hope we're going to learn from that. And so I think that so actually something else that we're doing in the back of this is we're actually going through what has been published research-wise, because we also have to be careful. Yes, a lot has been published, but what is the quality of what has been published? And if you actually look at, so we've just literally finished a bibliometric analysis of what has been published in the literature around cancer and COVID. So there has been a huge increase actually, or at least not a decrease in the number of studies that have been published, but what has happened is there is a shift. So the studies that we're publishing are not necessarily of the same level of high quality research that we were doing before. What we have been doing is publishing on our experience of how we're treating cancer patients. We've been reporting case studies, what kind of changes have we made in pathways. So there is a shift in what kind of studies are being published. So whilst we can say, yes, a lot gets published, I think equally we have to be very careful there of the quality of what is published, and there is a shift. It's not necessarily all what we would say hardcore research where you have like proper trials and studies where we compare. So I think it will be really interesting a year from now to kind of redo that analysis and kind of look at what the impact is of COVID on the quality of research published.
But it's interesting, the public who pay for most of our research, well, certainly that is funded through the agencies, the research agencies, might quite reasonably say, well, we want the information out there as soon as possible. And, it's interesting, isn't it? Because we've traditionally relied on this thing called peer review, where we allow colleagues to review our data and make judgments, and then that delays things, maybe sometimes by 6 months, actually sometimes by a year if it gets rejected. Whereas this COVID has taught you put it out there, and it's open to scrutiny by anybody who wants to look at it.
Yeah.
And I just wondered what you thought of that new model, of just putting your clothes out to dry and letting anybody scrutinize them.
Well, I think I'm not sure it's necessarily a completely objective process, because some people are just much better in selling themselves. And if you have a name of a big institution attached to it, then that's attention. And so, we might also miss very good research because people are less, good in advertising what they do. But on the other hand, I agree, it's frustrating. It sometimes takes a year for us to get our results out there. And with this process, it can all be there. But perhaps what is needed is some kind of hybrid model where there is some kind of scrutiny before it gets out there. And then in the background, yes, it can still take the longer time to get it published. Maybe that is the new way forward to kind of find an in-between solution. Yeah.
I suppose the other bottlenecks are, I think people have been very impressed how quickly collaborative groups have been set up. Whereas typically, to get precision, the MRI study, I think it took us 3 years to get a group together, to agree on a protocol. And in COVID, it was happening in within a week, within a few days, and they were getting a protocol finalized and submitted. It was really quite extraordinary. Never before have we seen such speed.
And I think that is a good thing. I think that we have learned that, we can all collaborate, and it's much faster if we all bring our skills together. And so I would hope that kind of has really encouraged, I see that myself, like, being I'm an epidemiologist, which means I analyze all the clinical data that we collect on patients. And I have done a lot of work using the data from Guy's Cancer Center, and look at the COVID patients. And I was just looking, we got 16 publications out there by working with the clinicians. And all of a sudden, everybody has identified that actually there is a team within the university that can help us. And all of a sudden, we're all working together. So I think there is definitely also what we call the silver linings of COVID. For me, as a person who deals with data, in a way, it's been really good, because we have much better collaborations with the clinicians and research is much faster. And we can actually address a lot of interesting clinical questions that come to kind of improve the patient experience and the patient outcomes.
good. One doesn't often hear silver lining and COVID in the same sentence, but it's very, very good to hear that. So one last question, I think, which I've heard from patients. So as we all know, clinical research needs capacity. So you need time to consent people, et cetera, do the extra tests. The NHS now is becoming overwhelmed. We heard on the news yesterday that A&Es were as busy as they have ever been. Clinics are full, hospitals are getting full now, and it's the height of summer. Is there any risk that research will be compromised just because the NHS is so busy trying to deal with the huge backlog that COVID has generated?
Well, I think it depends. I think we're lucky being in big institutions where there is a close collaborations between the university and the hospital. So I don't think necessarily it will stop research. If anything, I think it may still be good because there is much better collaboration. But what I really think might be an issue going forward is the funding. And we're doing some work around that as well. Funding has been cut a lot. I mean, I can tell you, I had 3 grants under review looking at global health and cancer. And even though I had written them and they went out for the review process, the government has pulled all their global funding. So all of the work we've done with all these countries across the world, well, was for no reason, because now we just have to wait until we find other opportunities and see how we can get it funded. So yeah. I personally am much more worried about that. I think, as much as our clinicians are under pressure, they very much care about their patients and they do want to engage in research. So I'm not too worried about that. I think we'll make it happen, but it's all about whether we can get the funding to keep all the staff employed. Yeah,
so the pressure on funding, so that's a couple of billion, isn't it, less from the Global Fund, and CR UK have had a huge hit. So Cancer Research UK, one of the world's biggest cancer charities, was hit largely because their shops didn't generate the income because they were closed, and most CR UK budgets have been cut by 20 to 30%. And now they're very, very confident that money will come back, and they're planning, or certainly predicting, a V-shaped recovery. So we should see those projects restored, hopefully. But you're right to raise this very difficult period that we're in. Okay. Steve, any new questions appear while Mika and I were having a private conversation?
No, we're good to move on, Mark.
Okay, great. Well, for the non-vegetarians, this is the meat and potatoes of the meeting. So this is where we're going to have a debate on one of the really hot topics in prostate cancer diagnostics, risk stratification, if you like. I think the world agrees now that if you can do an MRI, you should before you stick a needle in the prostate. I think there are very, very few people that would argue against that. So I suppose the subordinate question is how you do that MRI. Do you do the belt and braces approach, which is what we call multi-parametric MRI, or do you do a shortened version that doesn't involve an injection? And this is probably the hot question in prostate cancer early detection at present, and we're going to address it now. And so I've got two people who are going to debate this. So David Evans is going to argue for the simpler scan, and he'll tell us what that is. And then Viru Kazivithasanathan is going to argue against the simpler scan. So he's going to argue for the full parametric, multi-parametric MRI. And then Para Singh, who is independent, doesn't have any skin in the game, has not invested his pension fund in Siemens or Philips or any other MRI company, is going to adjudicate on that for us. And then, of course, there'll be a little bit of time for discussion, but I think this will generate a lot of interest. So, David, are you ready to kick us off?
Yes, I am. So hopefully you can see my screen. Yeah, and as Mark says, I'm going to be arguing in favour of a non-contrast or biparametric MRI as the first scan to diagnose men with suspected prostate cancer. And just looking at all the faces, I know there's quite a varied audience here, so quite different experience with prostate cancer, prostate MRI. So I'm going to try and keep this quite high level. and just very broad concepts. So standard multiparametric MRI includes a number of what's called sequences, which basically means using MRI to take different types of essentially images. And as Charlotte and Mark mentioned, multiparametric MRI currently uses T2 weighted sequences, diffusion sequences, and then finally contrast enhanced sequences. Now, when we're talking about biparametric MRI, we're saying keep the majority of these sequences, but just remove this final contrast-based sequence. And these sequences are done consecutively during the scan. So first you do the T2 sequence, that takes about 10 minutes. Then the diffusion sequence takes another 10 minutes. And finally, the contrast sequence, which takes about 15 to 20 minutes. And in order to do the contrast, you have to do a number of things. So first, you have to get hold of some contrast. You have to do lots of checks on allergy status, renal function, because it can actually be quite dangerous if people have had previous anaphylactic reactions or have renal failure. You then have to insert an intravenous line, which is difficult for patients who are needle phobic. And finally, after the scan has happened, during the scan, the patient has to be hooked up to a pressure pump so that the contrast can be given at the right time towards the end of the scan. So you can see that with all these steps, how giving contrast is takes by far the longest length of time. And if you were able to just do these two sequences, the T2 and the diffusion, the whole scan would be far safer, simpler, and cost effective. And this debate, it's been going on now for the last few years. And I would say that the evidence is growing now strongly in favor of doing non-contrast biparametric MRI. And rather than thinking about just removing a whole sequence, which sounds quite a lot, I think we should be conceptualizing this as just part of a process which MRI has been going through over the last decade. When prostate MRI was first introduced, there was actually a fourth sequence. Many radiologists use spectroscopy as an additional sequence over time, similar to contrast, but with increased experience, spectroscopy has essentially fallen away. Similarly, many centers were using endorectal coils, so devices like this were inserted into the back passage before starting the MRI. But again, with improvements with imaging systems and imaging quality, these have become much less commonly used. And now we simply use abdominal coils. So the question is whether the quality of MRI and our experience of interpreting the non-contrast sequences has improved to the extent that contrast could now be seen similar to these historic devices and will in itself become obsolete. And this, I think, is a really important question to answer because over time, we're expecting the demand for prostate MRI to increase by nearly a third. So if there's anything we can do to make the protocol faster, safer, and more efficient, then we should be investigating that option. So I'm going to suggest 4 reasons why I think biparametric MRI is the scan for the future based on diagnostic accuracy, acceptability, and accessibility. So first, diagnostic accuracy, which is clearly the most important question. You all want to know that the non-contrast scan has similar accuracy to the full scan. Now, there have been a large number of studies in this area, and these graphs essentially summarize all those studies for biparametric MRI on the left and multiparametric MRI on the right. And each study is a circle, and essentially the red dot is an aggregate of all those studies. And the bottom line is that when you compare sensitivity and specificity across all existing studies, there is no significant difference in diagnostic accuracy between biparametric and multiparametric MRI. And it's not just this meta-analysis. Almost all meta-analyses in the literature has reached the same conclusion. So in the BJUI, no significant difference in diagnostic accuracy. In prostate cancer, biparametric MRI offers similar, comparable test accuracies. And in the American Journal of Radiology, there was similar diagnostic efficacy between MP MRI and BP MRI. And for those people who are a bit wary about meta-analyses, which I am as well, but would prefer one high-quality study, there's a secondary analysis from the well-known PROMISE study led by Prof. Ahmed and Prof. Emberton, which concluded that IV contrast may not be necessary when MRI is used as a test to rule out prostate cancer. Now, there are some limitations of these studies, which no doubt Viru will highlight, but fundamentally, if you look at the totality of the current evidence, it is overwhelmingly supportive of biparametric MRI. But despite this strong evidence, there are a number of arguments against using biparametric MRI, which should be acknowledged and explained. First, although there are those large number of paired diagnostic studies, I do accept that there is room for further research and a need for prospective, properly randomized studies in this area. And these studies are in progress. Vera is doing one, and they will hopefully provide the final evidence in support of non-contrast MRI. Second, removing contrast may increase the number of indeterminate lesions, which can occur in about 1 in 5 men. But the solution to this, I think, would be to follow more of a stepwise diagnostic model. So rather than doing contrast in everyone, do the non-contrast scan first, and then, if needed, give the contrast to patients where it would actually make a difference. If the contrast isn't needed, then men can continue on the standard pathway to be discharged or have a biopsy. And then finally, some people argue that biparametric MRI is too dependent on image quality and radiologist experience. So if you have lower quality MRI sequences or less experienced reporters, then some people might suggest that contrast is needed as a backup to ensure consistency. But again, I would argue this fundamentally isn't the optimal approach to solving these issues. The solution to lower quality images or less experienced reporters is not simply to give contrast as a backup. Instead, we should be focusing on improving scanner quality and increasing training so that we don't have to give contrast in everyone. Because on the other hand, there are significant advantages to the patients of avoiding contrast. First, scanner timing. The contrast sequences, as we said, is the longest of all the sequences. So as I mentioned before, it turns what is essentially a 20-minute scan into a 40-minute scan. And having watched many hundreds of men going through the MRI as part of a trial called Prostagram, if they are even slightly claustrophobic or having difficulty lying flat for longer periods, then that extra 20 minutes to give contrast can be a real challenge for a significant number of men. There's also issues around cannulation. Lots of patients are needle phobic and don't like lines being inserted or being connected to a drip. And these factors mean that biparametric MRI is more acceptable to patients and means that more men will tolerate having an MRI which doesn't include contrast. And of course, contrast is not a free lunch. There are rare side effects, which although they're not common, when you start scanning large numbers of men, they will occur. So the most common is an allergic reaction, which can range from a rash to anaphylaxis. So for these reasons, gadolinium, which is the contrast, has to be given in a medical environment with staff on call who can treat anaphylaxis. Second, in patients with kidney failure, gadolinium can cause a fibrotic reaction, so causing the skin in the arms and legs to thicken and scar. And then finally, gadolinium is known to cross into the brain and can be detectable for long periods after the scan, although there's currently minimal evidence this does translate into a clinical condition, but we don't have the longitudinal data fully for that. But fundamentally, once you remove the contrast, you remove the main medical risks of a prostate MRI, and then it becomes a much simpler test with fewer constraints. And potentially, it means you can open up and provide prostate MRI in more places than just the hospital. And as Prof. Emberton alluded to just now, once we remove contrast, it becomes much easier to do MRIs in the community, rather than having to come to hospital for bloods, cannulas, and injections. And these mobile screening units have been used very effectively in both breast cancer and lung cancer, where trucks are sent out to hard to reach areas and engage higher risk communities who may not have normally engaged with healthcare screening. Because fundamentally, we are going to need a lot more scanners. And I did see, I think Simon from PCUK is on the line, and PCUK have made some very useful projections of the number of scanners needed if you use a biparametric MRI approach compared to a multiparametric MRI approach. And fundamentally, you need an extra 50% more scanners if you use contrast. And also, contrast takes longer for radiologists to report. So every year, you'll need an extra 32,000 radiology working hours if you do 100% contrast scans. And this is assuming that we're just going to use MRI as a second line test and no screening program. If this works. So these are the projected numbers of MRIs needed over the next 15 years if we keep the status quo in the standard pathway. But of course, as Caroline spoke about, there's that other strand of ReIMAGINE, and also Prostagram looked at whether MRI could be offered to even more men as a screening test. And if you do similar projections using MRI for screening, if this red line here is the status quo, then the capacity needed for MRI with screening looks something like this. And this is over the next 15 years. So rather than 200,000 scans, we would need capacity for around 4 million scans. So I'll just let you take that number in as a concept. So basically, looking to the future, if the goal is to ensure that every man who needs an MRI has access to one, then realistically, as we expand the indications for MRI, the only scan for the future, which is going to be feasible on a large scale, is biparametric MRI, because it's fast, it's non-invasive, and it can be done in a variety of locations. If you add contrast, the scan becomes too long, too expensive, and too limited to where it can be performed. And I accept that a little bit more research is needed to confirm diagnostic accuracy, but in terms of thinking about the future, I was asked to present the arguments why we need to focus on making biparametric MRI the first scan. And there may still be a role for contrast, but we need to be smarter and select those patients who would benefit from the addition of contrast. Thank you.
Fantastic. Thank you, David. That was great. You argued very ably that less is more.
Yes.
And we're going to hear from Viru now. Is it true, Viru, that less is more? Or is more more?
So, good evening, everybody. I hope you can hear me.
We can.
Perfect. So, thank you, David, for your very nice talk. And also, thank you very much for inviting me. I'd like to say congratulations to Mark for his OBE. It's a fantastic honor, and we're all very proud of him. I spend my day-to-day practice managing patients with prostate cancer. And in the last 10 years, I've spent this focusing on prostate cancer research in MRI. And let me tell you, we are not ready for biparametric MRI for prostate cancer diagnosis. And here's why. Here's what David didn't tell you. So these studies here, Precision, MRI First, Promise, and the 4M study, these are the major landmark studies which have allowed us to change our guidelines, our UK guidelines, the NICE guidelines, the European guidelines, the American guidelines. These have allowed us to use MRI before a biopsy. And all of these studies are based on multiparametric MRI, not biparametric MRI. If we want to change practice to biparametric MRI, we need the same quality of study in order to do that. David spoke about some of the meta-analyses and how they show that biparametric MRI is as good as multiparametric MRI. However, those studies have major flaws. First of all, the way that the MRI is scored, primarily in most of those studies, uses a system which already assumes that the contrast sequence has no role. If you use that scoring system, you will never show a difference. So it's important to design a study to be able to show one. In order to see what would happen if you didn't have the contrast sequence, you would need to perform biopsies to see whether your MRI is right or not, just based on the biparametric MRI information. However, the vast majority of these studies perform biopsies based on the full information, not on the biparametric MRI information. Because the vast majority of these studies weren't designed to compare the two types of MRIs together, the vast majority of them don't have enough patients to be able to make a firm conclusion about whether one is better than the other. And so, as David said, I agree we need some prospective studies which are appropriately powered to do so. When we actually look at a more recent study, which is of a higher quality, published a few months ago, which is a randomized study comparing the two together, you actually show that the multiparametric MRI nearly detects 10% more significant cancer than the biparametric MRI. And if it were appropriately powered, it would have shown that it was significantly better statistically. So I'd ask you, as members of the audience, if you're someone with suspected prostate cancer or a family member who might be being investigated, would you like to have a test that detects 10% less significant cancer when you know there is one better out there? The next thing to talk about, which David touched on, is the biparametric MRI information and how reliable it is. So we know that there is a lot more uncertainty with just having two sequences with biparametric MRI. And this study from a famous Dutch group showed that almost double the number of scans were scored as being uncertain. And there are good arguments to make for why a shorter scan might be cost effective. However, if you have a lot more uncertainty, many more men will actually undergo biopsy. So there's a lot of uncertainty about whether it is cost effective. It might cost more money, and you're putting men through potentially unnecessary biopsies. In addition, the contrast sequence, although it is claimed to be double the length with a multiparametric MRI scan to a biparametric MRI scan, in most units it's actually not. It's actually usually a 5 to 10 minute addition. So the projected number of MRIs and time you might save from doing a biparametric MRI was probably overestimated, and that's quite clear from all the peer review feedback when we thought it was double the time as well. So if you have a test which scores so many men as being uncertain, then it's not a very good test, because what you want really is you want it to discriminate between men who have cancer and men who don't. And this uncertainty doesn't help in this circumstance. So with biparametric MRI, you really need your two sequences to be perfect. You need the highest quality scanners, which we know in the UK are not available in every centre. You need the most experienced readers, and we know from the research that you need to have a good experience of reading MRIs to be at that level. You also need the patient to not move in a potentially 30-minute scan. They can't have any metal work, and they're not even allowed to have any gas in the rectum. That's not real life. In real life, we need contrast, because that will allow you to be able to account for these real life features to ensure that the MRI is of good enough quality. So if you don't believe what I'm saying, see it for yourself. Here are a few examples. This is a 62-year-old man with a PSA of 6. He underwent his MRI. On this MRI, you can see the peripheral zone on the standard biparametric MRI sequences, which looks quite nice. There's no obvious focal abnormality. When you look at the contrast sequence, you can see a contrast enhancing area in that left peripheral zone. That was biopsied, which showed significant cancer. So without contrast, this cancer would have been missed. Here's another example. It's a 71-year-old man with a PSA of 8. On his biparametric MRI scan, again, you can't really see any obvious lesion. When you look at the contrast scan, however, this lesion becomes quite obvious. It's that white area marked by the red and yellow arrows. That was biopsied, and again, it showed significant cancer. Without contrast, this cancer would have been missed. Let's take a third example, a 73-year-old man with a PSA of 9. On the biparametric MRI on the image on the left, you can see there's not really an obvious cancer. When you look at the image on the right, there is this white area marked by the green arrow. However, this is actually an error. It's what we call an artifact, which is caused by rectal gas. When you look at the contrast information, this actually highlights this. You can see the dotted line, which shows you where the actual lesion is, and it's actually in a different position to what would have been suggested by the previous scans. This area, which enhanced on contrast, was biopsied and showed significant cancer. Without contrast, this cancer would have been missed. So we've talked a lot about the diagnosis, and that is very important. But something that people very rarely talk about is the role of the contrast and the multiparametric MRI in the staging of disease. So looking at how far the disease has gone outside of the prostate, what key structures are involved. And in addition, after men who fail their initial treatment, how disease is found out afterwards. So multiparametric MRI in contrast is particularly useful for accurate staging and making the right treatment decision for a patient. So contrast is well known to increase the confidence of the radiologists in being able to identify whether the cancer has spread to areas such as the urinary sphincter and the bladder neck and the seminal vesicles and around the capsule. And all of those involvement of those structures are important to be able to decide which treatment is the right one. And once you decide which treatment to give, how you give that treatment so that you can maximize the benefit to the patient, increasing their chances of cancer cure, whilst minimizing the harm that they undergo. So let's take an example for a man undergoing surgery, a radical prostatectomy. If we look at this 66-year-old man who underwent radical prostatectomy, this is his MRI. You can see his prostate here on the biparametric MRI. This yellow dashed line shows the edge of the prostate. The blue circle shows where the nerves are, and these nerves are important in maintaining the erections. The biparametric MRI actually does quite well here in identifying the cancer. That's marked by that red area. Because the cancer looks to be quite close to where those nerves are, the surgeon will actually decide to take quite a lot of tissue around the prostate out with the prostate so as to make sure there's no cancer left behind. But the consequence of that is that they can't save the nerves. And the result of that is that this man will have erectile dysfunction. Let's look at the contrast sequence for this same patient. You can see that the lesion is marked by that bright white area, and that area is slightly more distant from the edge of the prostate than initially thought. You can see there's a bit of room to spare. As a result, with the contrast information, the final decision was to save the nerve. And this man would therefore have erectile function preservation whilst having a cancer cure. Now, the last point I wanted to mention was about detecting recurrence of disease. Now, we know this affects around a third of men whose initial treatment won't work, whether it's surgery, whether it's radiotherapy, whether it's focal therapy. So when looking at the biparametric MRI for a particular gentleman, you can see there are these black round areas. These are actually seeds from previous radiotherapy with brachytherapy seed treatment. You can see on this image, there doesn't actually appear to be any abnormality. When revealing the contrast information, this has been highlighted with some color pixels. You can see this red area, which marks up very clearly as contrast enhancing, which was biopsied and showed significant cancer. Without contrast, the cancer would have been missed, and this gentleman's prognosis would have been a lot worse. So to summarize why we're not ready for biparametric MRI, the data from the leading studies supporting the use of MRI is for multiparametric MRI, not biparametric MRI. Data suggesting that both are quite similar is flawed. In real life, patients have variation, and the equipment we currently have available to us means we need to have a bit of a safety net with the contrast information. We've talked about the role of contrast and multiparametric MRI beyond the diagnosis, also in the planning of the treatment so that the right man gets the right treatment and done in the right way. And finally, it's important for finding out when disease has come back. So I hope you understand and agree with me that we're not quite ready for biparametric MRI yet, though I fully agree with David that it's important for us to carry out studies to investigate this to find out whether it's a possibility. Thank you.
So thank you, Viru, for making me feel nervous about dropping the gadolinium in our patients. So really, it falls to Paras now to kind of reflect on two fantastic lectures. I've heard this debated before, but never so well as today. And part of the reason for bringing Paras to you is to introduce him to you. He's new on the ReIMAGINE front. He's leading the ReIMAGINE trial at the Royal Free Hospital, and we're incredibly grateful to him for getting the trial up and running there, and is managing to recruit lots of patients to ReIMAGINE. So he's very interested in this debate. Personally, I know, because they have used biparametric imaging at the Royal Free. So I'll ask now Paras to come and give a reflection on those two talks, and what we might take forward. So Paris, over to you.
Thank you, Mark, and congratulations on your OB. I have not made any slides because I thought I would listen to these excellent talks first and then give my take on these. David, it was a difficult task for you to swim against the tide, and Viru, you tried to convince us, and we are already convinced about multiparametric MRIs and know the use of multiparametric MRI in our routine practice. Based on the studies, I think multiparametric MRIs, we have no doubt that they give us good information, both in the diagnosis and also for staging and monitoring treatment of prostate cancer. The only question is whether the multiparametric MRI will survive the test of time in the screening setting, where we are trying to get a lot of patients, a lot of men, not patients, a lot of men who will probably go these scans just based on their PSA level, or not even based on their PSA level. They might be shopping in Tesco and just turn up at the MRI, the parking lot. If we're trying to go to that setting, then more likely, but biparametric MRI might be of better use, especially if that projected growth of 4,000 MRIs a year is to be realized by 2030 or something like that. Then I think we have to look at clever ways of screening. And just looking at the figures, we at our center, we do multiparametric MRI at the Royal Free, and we do about 45 MRIs a week. Even if we save 20 minutes as per David, or 10 minutes according to you, we'll be saving about between 7.5 to 15 hours a week on these patients. But of course, we need the evidence for that. And I think you guys are working towards that evidence. We have a trial that I think we're working together on that. And there are other trials also coming which are supporting biparametric MRI. And I think Viru cheated a little bit when he went on to the staging and post-treatment settings while trying to convince us on multiparametric MRI. I think that we have no doubt that the multiparametric MRI is useful in that setting. I don't think biparametric MRI will ever be able to beat that.